And let's just get started. So I'll tell you a little bit about me. My parents are both Vietnamese. They immigrated from Vietnam to Europe and then to Los Angeles, California, which is where I was born. And when we were 3, we moved to Denver, where my brother was born, and I spent most of my life in Denver until I left for college. I went to California, where I attended Stanford University. And while I was there, I spent a lot of time really trying to figure out what I wanted to do with my life. I wasn't ever the type of medical student who always knew that I wanted to be a doctor. I had a lot of relatives who are physicians, but neither of my parents were doctors. So I never really considered it until the end of college. And I tried a lot of different things before deciding to choose medicine. I also actually didn't ever think that I was competitive enough or smart enough to go to medical school, and actually had considered other careers after I got my first C in organic chemistry. So I was scared away from medicine for a while. And so after some time, I found a major that sparked my interest, and that was product design. So if any of you have ever heard of the Stanford D School, the product design major was a large part of that program, and it's a subset of mechanical engineering with a focus on creativity, aesthetics, as well as human factors. And I really love product design because it emphasized teamwork and creativity. And really, I could talk on and on about how much I loved product design, but ultimately when I graduated in 2013, I still wasn't sure what I wanted to do with my major and the new skills that I had acquired. So I worked for various health tech companies in the Bay Area, one being Doximity, which some of you might know. And I did some research at Stanford and in the School of Medicine. And during this time, I actually stumbled upon some physiatrists at Stanford who were teaching a class called Lifestyle Medicine, as well as a musculoskeletal medicine class. And they kind of took me under their wing. So I started doing some research with them. And after getting to know them, getting to know what they did, I became a lot more interested in medicine, and specifically in becoming a physiatrist. So 2 years later, I ended up going to medical school at the University of Colorado. And currently, I am a second-year resident at Vanderbilt in physiatry. So some of you might think that it seems like I always knew that I wanted to be a physiatrist even before I went to medical school. And you might be right. So today I'm hoping to tell you a little bit more about physiatry so that, just like my mentors at Stanford, I might inspire some of you to become physiatrists. So what exactly is physiatry? Aside from kind of a cool word that sounds like psychiatry, physiatry comes from the Greek word physikos, which means physical, as well as atresia, which is the art of healing. And it's a very broad field that specializes in a philosophy as opposed to an organ system. So that's actually something that makes our specialty very unique. So as opposed to other specialties that focus on organ systems, such as cardiologists who focus on the heart or pulmonologists who focus on the lungs, and diseases that correspond to these systems, we actually focus on prevention, restoring function and independence, and maximizing quality of life. So we're considered the medical experts when it comes to maximizing function that has been lost through injury, illness, or other conditions. And we're big on wellness. We promote wellness via a very thorough understanding of our patients, and we work in teams with other healthcare professionals, which I'll tell you a little bit about later. And one of the things about physiatry is that it's a newer subspecialty area of medicine, which is why a lot of pre-meds and medical students don't necessarily know as much about it. We were first recognized as a specialty in 1947, but our field really began to develop during World War I, through World War II and the polio epidemic. And during these time periods, there was an increasing need to take care of injured vets who were returning from combat, as well as those patients who continue to live with chronic disabilities and weakness that also can often be seen after neurologic diseases such as polio. And as a more current and perhaps relevant example, as you probably know, post-COVID-19 patients often have significant sequelae and impacts with complications such as stroke or pulmonary deconditioning, or difficulty swallowing, which we call dysphagia. And all those things also lead to rehabilitation needs after they are acutely hospitalized for COVID. So those are some other patients that we are currently taking care of as well. So physiatrists treat a broad range of conditions and work with diverse patient populations. And I like to think that any patient really can benefit from a physiatrist. So that includes everyone from Olympic athletes to tetraplegics, stroke patients, traumatic brain injury patients. And when I think of the organ system, if we had to pinpoint some organ systems for physiatry, I tend to think of the neurologic and musculoskeletal systems. So within those systems, some of the conditions that we treat in the neurologic system, for example, include brain injuries, spinal cord injuries, stroke, multiple sclerosis, and Parkinson's. And within the musculoskeletal system, we treat patients who have suffered amputations, patients with osteoporosis, arthritis, and work and auto-related injuries. Pain is another big symptom that we treat. And as you probably know, this pain can come from joints, bones, muscles, ligaments, tendons, bursa. We also treat a lot of back pain as well. And we also oversee rehabilitation programs, for example, for patients with primary cardiac and pulmonary problems. So that can include patients who are post-transplant or who recently had a big open heart surgery, patients who have severe lung conditions such as end-stage COPD, and other conditions as well. So some of the diagnostic tests that are within the scope of practice for physiatrists include X-rays, MRIs, CT scans, and ultrasound. So ultrasound is a very important skill for us. And if you look in the right-hand corner, that's a small portable ultrasound device machine that we call a butterfly. It hooks into your iPhone and allows you to use an app so that you can look at different muscles, joint tendons, and other pathology. So that's a skill that is very important for us. Nerve conduction studies and EMGs are another relatively unique skill to physiatry, and that's something that we also need to have experience in. So nerve conduction studies evaluate the function of motor and sensory nerves, which helps distinguish the location of a nervous system lesion. EMGs, or electromyograms, help distinguish whether weakness is due to muscle or nerve dysfunction. And we use EMGs to diagnose these conditions. We do so by inserting very thin electrodes into the skin and detecting the electrical potential generated by the muscle cells, which help us elicit pathology. So nerve conduction studies and EMGs are a big part of physiatry, and they can be a difficult concept to kind of understand. So I'm going to play a quick video for you that gives you an idea of what nerve conduction studies and EMGs entail. So let's see if we can fast forward this. And go right here.
Especially for you based on your symptoms. So the length of the test is different for every patient. Usually it takes between 30 to 60 minutes. First, the technologist or doctor may warm your body by wrapping you in a blanket or soaking your hands in water. Warming your body helps them conduct the best study possible. Then there are two parts to the study. First, the nerve conduction study uses small electrical shocks to study your nerves. You need to relax your muscles during this portion of the test. Some patients report that this feels like a series of carpet shocks. Next, the needle EMG uses a small needle to evaluate your muscles. The doctor may ask you to move a certain way while the needle is in the muscle. You may feel some discomfort during this portion of the exam.
So that kind of gives you an idea for what nerve conduction studies and EMGs entail. Other things that we do, so the treatments that we offer, we do not perform surgery, so we're strictly non-operative. Rather, we treat conditions non-operatively in the form of different modalities that can include injections. So we do peripheral joint injections to diagnose and treat disorders. Let's see. We also use trigger point injections, which we use more as an adjunct treatment for myofascial soft tissue pain. And certain specialties within PM&R, like interventional spine, they use fluoroscopy to provide non-surgical pain relief for back pain. We also manage spasticity, which that's a term that describes stiff or very rigid and tight muscles. And we do that by doing Botox injections. Along with that, we also prescribe oral medications and manage baclofen pumps, which are all other modalities used to treat spasticity. We also oversee rehabilitation programs. So like I mentioned earlier, we work in interdisciplinary healthcare teams, and other members of the team include physical therapists, which are sort of the specialists who help patients improve their movements, occupational therapists or OTs, who specialize in helping patients to maintain the skills that they need for daily living and working, being able to do things such as getting dressed and using a pencil, and speech language pathologists or SLPs, who are experts in communication and swallowing disorders. So SLPs help patients improve their language and social communications. And those are all members of the rehab team, which physiatrists oversee. And physiatrists are really the leaders of this team. We're the ones who prescribe these therapies, just like other physicians might prescribe a medication. We also work closely with patients to provide them with adaptive devices as needed. Prosthetics, for example, are artificially made limbs that replace a part of the body that's missing. Orthotics are devices that are used to correct or enhance the function of a body part. So those are all things that we should have skills in. And additionally, we perform other procedures such as acupuncture, platelet-rich plasma injections, both of which are relatively new. All right. So physiatry is a medical specialty, and as becoming a doctor always is, becoming a physiatrist can be a pretty long road as well. There's an additional 12 to 13 years of training in order to become a physiatrist after high school. So that includes your 4 years of undergraduate, 4 years of medical school, and then you do 1 year of an internship, which is usually in internal medicine, surgery, or a transitional year. And then physiatry residency itself is 3 years. And then you can do a 1-year fellowship afterwards if you'd like. There are over 80 accredited PM&R residency programs in the US. And as I'd mentioned, fellowships are optional. A little under half of physiatrists, so about 43%, actually complete a fellowship. And so people often ask me what residency is like since I'm a resident. And in general, residency programs in PM&R tend to be small, much like ophthalmology or dermatology. Our program size ranges from 2 to 14 residents per class. And in my class, there's a total of 4 of us every year. In terms of requirements to complete residency, it's pretty simple. You have 12 months of required inpatient rotations. And here are some examples of the teams you might be managing on your inpatient rotations. So you might see patients with general deconditioning, neurologic disorders, stroke, brain injury, spinal cord injury. And then as far as outpatient rotations, you have 12 months of outpatient, and there are a handful of outpatient electives, which are required depending on your program, and others which you can pick from. So some of these, just pulling a few out, they include amputee clinics, EMGs like we had just seen, spine, sports medicine, and those are some of the more popular electives. And then finally, you have 12 months because you have 3 years of residency total. The remaining 12 months, depending on your program, can be a combination of inpatient and outpatient months. You also have 6 months maximum that you can allocate for research. So there are opportunities to become part of a rehab medicine scientist training program if you're interested in becoming a researcher or want to learn how to obtain NIH or other research funds. And then call is another topic that residents often like to ask about. So people like to know how often you are responsible for the hospital overnight and on the weekends. And again, that really depends on the program, and it ranges from in-house call, so where you have to be in the hospital, sleeping in the hospital, in-house call every 4th night, to at-home call where you're actually sleeping at home every 11th week. And not to go too much into the details, but those have their positives and negatives. And at my program, we take at-home call, and we take most of our call our second year. So I take a total of 8 weekends where I'm actually on call and 26 weekday calls. And from every year here on out, I take progressively less call. And really, all that said, I don't take that much call as a resident is the bottom line. And I also have most of my weekends free, which is pretty rare for residency. So that leaves me a lot of time to become involved in other extracurricular opportunities that include recruitment and helping to recruit incoming residents, working with medical students and pre-medical students such as yourselves to tell them about PM&R and to spread awareness for our field, and research as well. So there's many opportunities to do other things. And one thing that I think is also pretty unique about opportunities given the time that we have in physiatry residency as well as within my program is that I work very closely with the Entrepreneurship and Design Center at Vanderbilt. So Vanderbilt Medical School is very close to the business school. And given that I had a background in product design, came from Stanford, I have a very big interest in healthcare technology and entrepreneurship. So I've been fortunate enough to help mentor some of the health tech startups founded by postdocs, MBAs, and others. And I feel very fortunate that I have time to do these things and build my career even while being a resident. So another important thing to think about is what happens after residency. So as mentioned, a little under half of physiatry residents choose to pursue a fellowship. And in theory, it's not required since PM&R is already a specialty itself, and you should be able to practice physiatry without a fellowship. But if you decide that you want to pursue that extra training, here are some fellowships that physiatrists can pursue. So that includes hospice and palliative care, neuromuscular medicine, pain, pediatric rehabilitation, spinal cord injury, sports medicine, and traumatic brain injuries. And those are the ACGME accredited fellowships. So the accreditation, there's a committee that, much like medical schools, basically sets standards and quality assurance for certain programs. And so that makes those fellowships a little bit more competitive. But there's also some non-ACGME accredited fellowships. So some doctors also specialize, or some physiatrist doctors also specialize in cancer rehab, multiple sclerosis, neurorehabilitation, research, and interventional spine. And the great thing about physiatry is that it's still a specialty, but it's broad enough that you can really make it what you want it to be. So after all of the training is finally over, what is life actually like for a practicing physiatrist? So depending on if you choose to pursue a fellowship, you can work in a variety of different environments, including in the hospital, outside of the hospital, and in consulting roles. We practice in academic settings, group practices, and even solo practices. And some of the places where you might see a physiatrist include a sports medicine clinic, neurology clinics, in an acute care hospital, a rehabilitation hospital, skilled nursing facilities or nursing homes, and others. And as mentioned, PM&R is a team sport. So we talked about some of the other team members that we work with and we lead, but we also interact with other physicians such as neurologists and orthopedic surgeons. And below are the list of the other team members that are part of our team, as mentioned earlier. So there are a lot of reasons to choose physiatry, only some of which I've listed here, but here are some of my reasons for choosing this career. So physiatry is a really meaningful specialty, and that also leads to a really meaningful career. So whereas most patients often don't want to be in the hospital or to see most doctors, quite frankly, many of our patients are excited to see us because they want to get better and they're motivated to get better. And it's incredibly meaningful to work with these patients who can be young or old and who have just suffered from a traumatic event, such as a spinal cord injury or a brain injury, and help them adapt to their new disabilities so that they can get back out to living their lives. We can also follow these patients longitudinally, so we don't just have to see them in the hospital, we can see them outside as well, and we can build very meaningful relationships with our patients. Like I mentioned, our patients are very motivated and they want to get better. Our patient population can also be very diverse, so you can really choose the type of patient you want to work with. Whether you like kids and want to focus more on pediatric rehabilitation, or you want to focus on sports and work with Olympic athletes, paraplegics. There's even a new specialty called pelvic floor rehabilitation. And so that allows you to work with women, postpartum women, or women who have just had children, and work on their rehabilitation as well. It's a multidisciplinary field. So if you like neurology and musculoskeletal medicine, you can do a little bit of both as a physiatrist, and you can also work together in a team with other team members, as we talked about, and lead a team of healthcare providers. Lastly, physiatry is full of opportunities. So as a relatively new and lesser known specialty, like I keep saying, you can kind of make it what you want it to be. It is becoming increasingly competitive each year because more medical students are hearing about it. And we've actually been one of the few specialties that has not gone unmatched, meaning that every residency spot gets filled for the past few years. And this isn't the case for most specialties, actually. Even within residency, physiatry gives you the opportunity to have significant work-life balance. I do have most of my weekends off, and that gives me time to pursue other interests. And one other thing is that, salary is never the end all be all, but having a stable salary also is important in helping you to pursue other opportunities. So we make a competitive salary compared to most primary care specialties as well. So lastly, the last thing I kind of want to talk about is to give you all three pieces of advice just based off of what I have learned and what I have experienced in my training. And my first advice is really to pace yourself. So everyone says that medicine is a marathon. It's not a sprint, and it really is. Once you're in residency, I'm only now beginning to realize that. But you realize that exams never end, and you're always studying for the next exam. So that said, it's important not to look too far into the future and to really concentrate on what you're doing now. So you can do it well, because if you do a great job with what you're currently doing, that will open more and more doors. I think the thing that goes along with that also is to try to enjoy the moment. It's really hard being a pre-med, really hard in medical school, really hard in residency too. And I know that I used to be very guilty of telling myself, making excuses more so by saying things like, once I get into a good college, I can stop worrying and be happy. And once I go to medical school, I can finally stop studying and be happy. And in some ways, I had always used the next big accomplishment or the next big thing that I had to do as an excuse to not be happy in that moment and not to enjoy the moment. And that can really get to you. So now that I'm a resident and looking back on my training, I just have realized that board exams never end. I'm already studying for my next one. And I just took one 3 weeks ago. So you really have to be happy with what you're doing in the moment, because really, once you see all these patients, especially in physiatry, some of the sickest patients, you realize that life is too short not to be happy. And when you do these things, I think it opens you up to be free and to be willing to embrace different opportunities. So as you can imagine, when I got to Stanford, it was full of very smart people, and I felt very much out of my league. Some of my classmates were starting their own companies during the week, and then they were also hanging out with me and fountain hopping and tailgating during the weekend. And I kept comparing myself to other people and trying to look for my passion and not really knowing what they were or what I wanted to do. And I tried a lot of different things, maybe to a fault. But had I not majored in product design, and had I not taken that lifestyle medicine class, and had I not met those physiatrists, I probably wouldn't be doing what I'm doing now. So I think the people with the most interesting careers are those who have tried many different things and found ways to combine different disciplines. And that's something that I've tried to emulate in my career. So I'd encourage you all early in your training to try a lot of different things, explore a lot of different specialties, and really figure out what you want to spend your life doing. And lastly, I think this is one of the most important things I've learned, is to keep your friends and family close. And especially through all this training, I've realized that being happy in life is really about making time for your friends and family. And I realized that were it not for my friends and family, I probably wouldn't be where I am today. So in medical school, I lived with my parents. I had home cooked meals and free car rides. And as a resident now, I live very close to my in-laws, and I continue to benefit from all of those things. I now try to make time to talk to my college friends. And as we get older, it can be even harder to make time to do those things. But it's so important just to remember what's truly important. So here are some references and resources. If you're learning more about physiatry, the Association of Academic Physiatrists and the American Academy of Physical Medicine and Rehabilitation are two great resources. They have a lot of information both for pre-meds, medical students, and I took a lot of my information from both of those websites. So I recommend you look into that if you're interested. And as always, I just wanted to let you all know that I'm happy to answer any questions. You can also message me on Instagram if you're a medical student or pre-med. I'm trying to be a resource to all of you, and you can also follow me on Twitter and check out my blog as well. And so I hope that we, let's see. Maybe there. I hope that you guys all got to learn a little bit more about physiatry, and I'll take any questions.
Thank you so much for this presentation. That was really helpful. Super awesome. Thank you. So there were a ton of really good questions in the chat. So we'll just start out with doing some of the most common ones that we got. And so people were asking, you know, what are the differences, if there are any, between DOs working in PM&R and MDs? And do you think there's an advantage to DOs? Because a lot of people were saying they see a lot of osteopathic medicine in what you were describing.
Yeah, I think that's an excellent question. I think especially recently there's been all this talk about, you know, DOs versus MDs. And essentially our training is very similar in DOs get more training in OMM, so osteopathic manipulative medicine. And that is actually a lot of reasons why we have a lot of DOs within PM&R. I trained at an MD school, so I don't have as much experience with the different sorts of training that DOs do have, but I do know that that is a huge benefit for DOs going into PM&R, is that they have the different background and they've spent a significant amount of their 4 years focusing on musculoskeletal medicine. So I think there are advantages, and yeah, there are certainly advantages.
Great, thank you for that. There were also some questions asking, what are the possibilities for PAs or NPs in PM&R, and how closely you work with them and other mid-level practitioners?
Yeah, that's also a great question. So we work very closely with them, actually. So at my hospital, at our rehab hospital, we have nurse practitioners who help us with admissions, who help us with some of the day-to-day questions that don't necessarily require an MD, but they take a lot of that off of our plate. NPs, I guess at our program, they're always overseen by a medical physician or a medical doctor. So we are supposed to supervise the NPs, PAs, and mid-levels, but they can be very helpful to us as well, and we work closely with them.
Thank you. So there was one question that a lot of people wanted to hear about is, first of all, thank you for mentoring pre-meds, but also how have you handled your mental health and trying to avoid burnout throughout medical school and residency? Because a lot of the pre-meds are starting to already feel some of the burnout.
Yeah, certainly. I think that medical training is so rigorous and there's such high expectations for us. I think that the reassuring thing, if I were to tell myself as a pre-med, looking back to when I was a pre-med, is that it does get easier. Things become less competitive. Every year of medical training, you get more and more experience that not only makes you feel more confident, but people also start to trust you just a little bit more. And you start working together with your colleagues, because early on, it can seem like, you know, everyone wants to do everything and everything is so competitive, kind of like how I felt taking organic chemistry and getting my first C in organic chemistry. But that doesn't last, and it gets better. For me, I really try to make time for things that are important to me. I also chose physiatry and chose my specialty because lifestyle and having a work-life balance are very important to me. And I didn't want to wait until after residency to achieve some of those things. So I think that the decisions you make as you get further and further along in your training can really help with your work-life balance as well too. And it does get easier.
Thank you for that. As we had something a little bit more PM&R specific, Carly asked, have you ever had the opportunity to perform Botox during your residency? She's worked in the brain trauma unit and saw numerous patients receive that from PM&R physicians, and they use EMG guidance to perform it.
Yep, certainly. So, and I think every program is different. For our program, we are required to have an EMG rotation. So I haven't actually done that rotation yet. But that is our third and fourth years. We'll be spending a month in EMG clinic. As far as Botox injections, we've practiced on mannequins, and we've had people come in and show us how to do Botox injections before COVID. And this was also before I was a resident, but we had cadaver lab. So every Friday afternoons, we would go into the cadaver lab, and we'd actually be able to practice some of these things on cadavers. And hopefully we'll be able to bring that back after COVID is over, because that's something I would really like experience in. But that is part of our training, at least at Vanderbilt.
Great, thank you. So you had mentioned that you don't do surgical treatments, but there was a question asking, are there any opportunities for surgical specialties to also become PM&R certified, or is there a way for surgical specialties to kind of get that like rehabilitation, more holistic treatment of patients?
Yeah, I think, so that's a great question. I think so there's not like a PM&R certificate or a PM&R type fellowship that you can do after having done a surgical residency. I will say that more and more we are seeing a lot of surgery residents, like prior like ENT residents, general surgery residents who do a year of surgery and kind of decide that they want a different, whether it's for lifestyle or whether they have different interests, they do come over and actually, we've had applicants from those residencies who switch over into PM&R. So that's not the ideal way to necessarily do it, but some residents have done like a surgical prelim year and then switch over into PM&R. But other ways from a surgical, like if you're planning to pursue a surgical residency, there's various different fellowships within surgery that are kind of separate from PM&R, because as physiatrists, we are strictly non-surgical. We do a lot of procedures. So if you're thinking about doing things in the fluoro suite or doing like spine injections, those are things that we do, but we don't operate.
Okay, great. Thank you for clearing that up. So kind of bouncing off, you said that you were, into engineering, and there seems to be a lot of engineers in the audience today. So they were asking how often you work with biomedical engineering solutions for rehabilitation, and they used an example like exoskeletons and things like that.
Yeah, so that's one of the great things if you are an engineer. One of the great things about PM&R is that it kind of, I guess, dovetails off of engineering very well, because just like you had mentioned, exoskeletons, whether it's stroke patients and assistive devices, orthotics, prosthetics, wheelchair design, those are all things that can be approached from an engineering perspective, and those are things that we as physiatrists need to know, and we do get training in those areas. So for me, I think it really depends on what kind of engineering you're interested in. So at Vanderbilt, working with the Entrepreneurship Center, I have been able to work with, I think she's a postdoc. She's doing a project where she's designing a device for stroke patients, helping them to use assistive devices such as like spoons or other utensils, to see if she can both prototype as well as create a physical a physical rendering of those devices, and she obviously needs stroke patients to trial those devices on. So my role was kind of to serve as the liaison between the engineering side as well as the medical side. So once she gets that physical prototype, I'll be setting her up with some patients over at our hospital. So there's different ways to still use your engineering background if you are an engineer. It just evolves as you get further and further in your training, because once you are in medicine, you're kind of more on that clinical side. So you're not so much the person designing those devices and creating those tools. You're more of the liaison between the engineers and the patients.
Thank you. We had one question, actually multiple people asked this question. How has the pandemic changed how you're doing your residency, and how going forward the practice is going to be for physiatry and PM&R in general?
Yeah, that's also a great question. So as I'd mentioned, we do 1 year in internal. I did a year in internal medicine, so I was over at the acute hospital at Vanderbilt. I spent, I think it was 2 to 4 weeks in the ICU, and that was in March. So just before the pandemic, just about the time that the pandemic was really starting to take off. And we didn't really know much about COVID at that time. So since then, things have really changed and evolved. And in July, obviously, I switched from being an intern to a resident, and I started over at the rehab hospital. So given my experiences, though, in the ICU, there are times where, I might be, and I guess I don't necessarily know the details yet, but we are able to provide help in the acute hospital if needed, simply because we had that training. We had a full year of internal medicine, so we know how to take care of acute patients, both in the ICU as well as on the floors. So that helps us both work in the rehab hospital as well as in the acute hospital. In terms of things that we're seeing, we actually do have a lot of patients who come to us after they've been at Vanderbilt, and after they have been hospitalized for COVID, and we're seeing more and more that there's a lot of potential for rehabilitation, because as you probably know from listening to the news and from talking to other people, the effects of COVID we're finding out more and more that there are a lot of long-term sequelae. So I know that that's, not necessarily something that we at the rehab hospital have like a designated post-COVID team yet, like a post-COVID rehabilitation team. While we have like post-stroke teams, post-traumatic brain injury teams, we don't have a post-COVID team yet. But I could certainly see that in the future if more and more of these cases do show up.
Thank you. I mean, that's unfortunate, but thank you. I guess kind of going off of that, what are some typical symptoms or conditions that you're met with on a regular day? Because, obviously you're going to start seeing post-COVID patients, but for right now or pre-COVID.
Yeah. Do you mean in terms of COVID patients, or do you mean in terms of?
In general, just like what you would see on a day-to-day on average.
Yeah. So I'll talk a little bit about inpatient and a little bit about outpatient. So on inpatient, we have different, at our hospital, we have different specialty teams. So I just got off of the general medicine team, and a lot of those patients just had a heart transplant or a kidney transplant, and we have to manage a lot of their immunosuppressants. And so there's a lot of following up of labs and figuring out what the right level should be, and talking to pharmacy to adjust their medications. If I'd also had recently been on a spinal cord injury team. And so those patients, after they are hospitalized at Vanderbilt, they come over to us and we help them to adjust to their new disabilities. So some of the things that spinal cord injury patients have to manage include bowel and bladder functions. They have to learn how to either in and out cath themselves or be started on a bowel program. They have to learn how to use a wheelchair, for example. If they're going to need that, they might have to learn how to use to gain some of their strength back as well too. In the rehab hospital, a lot of the things that we see, especially because they come from Vanderbilt, and by the time they get to us, they've had a very prolonged hospital course, so they tend to be pretty sick. So it can actually be sort of stressful because we have to manage things that might come up, like some patients might get new urinary tract infections, some might have new chest pain, and then we'd be concerned for, a heart attack, or some of the brain patients on the traumatic brain injury service, we might be concerned that they might be having like a hemorrhagic stroke or hemorrhagic stroke conversion. So we have to watch them pretty closely while they're doing rehab and just make sure that they're not any new symptoms that we need to work up further.
Great, thank you so much for that. So there were some questions kind of going back to undergrad, and if someone knows that they would like to do PM&R and that's something they're interested in, is there an area of research that you recommend they start working on or kind of looking into, or like something that you did or what you would recommend to them?
Sure. So my interest is in sports medicine, and I'm hoping to do a fellowship in sports medicine. Sports and spine tend to be two of the more competitive PM&R specialties. But really, PM&R is so diverse that it's important to kind of understand exactly everything that it entails. So learning from sort of my own mistakes, I was so focused on being a sports and spine doctor that I didn't really realize what it was like to be an inpatient rehab doctor. And I'm spending, the next year of my training doing a lot of inpatient stuff. And I think that a lot of programs will also appreciate if you can really fully understand sort of the idea and the scope of PM&R. So trying a lot of different things and making sure you know what inpatient rehabilitation is like, what it's like to take care of patients with disabilities, and also knowing what it's like to take care of the full spectrum of patients, I think is really useful. So I don't think that there's any like one particular area of research or interest that would be particularly helpful, but I do think, really understanding like what it's like to be a neurologist, a musculoskeletal medicine doctor, those are the two kind of organ systems that we focus on, are good places to start. But I think it's also important to understand the whole spectrum of PM&R.
So there was a really good question asking about, I guess, minority representation in PM&R in your patient population. And so would you say that your patient population is largely financially privileged? Do PM&R therapists, do you focus on overall well-being rather than like just the people that come in to see you? Do you go out and get patients to see you, kind of raise awareness? If you could talk a little bit about like minority representation.
Sure. So I think that really also depends on the scope of your practice and where you practice. Obviously if you're going to be working with Olympic athletes or, doing more of like concierge medicine, that's a very different population than, traumatic brain injury patients. The majority of traumatic brain injury patients or spinal cord injury patients. There's really quite a spectrum. You can work inpatient, you can work outpatient, you can work at an academic facility, or you can work in solo practice. So we do get quite a variety of patients. And the other thing is that, to talk about what types of patients we usually see, most of the patients most patients in general who have traumatic brain injuries are male, are usually, I think, like in their teens to 20s, kind of because those are the patients who experience trauma more often and like motor vehicle accidents more often. So you will be skewed based off of, if you choose to do that versus if you choose to do pelvic floor rehabilitation, which is going to obviously be just women, or mostly women, or after they've had kids. So there's really, as I kind of had mentioned, I think everyone can benefit from a physiatrist, and you can really choose your patient population, but just being aware that depending on what specialty or what further subspecialty you choose within PM&R, that might kind of limit the patients that you see.
Thank you. I guess we're going to take two more questions. One is, maybe you can answer this. Can you practice as someone who specializes in PM&R in other countries?
So rehabilitation medicine is, I know that, so one of my cousins is a physical therapist actually in Belgium. And so that is something that's a specialty that they recognize, rehabilitation medicine. I have, through Instagram, have been connected with some physiatrists in other countries as well too. If you are someone who is interested in international medicine and, maybe traveling to a third world country and working with those populations, I certainly think that that's, you just have to be creative, really, is how I see PM&R. You kind of have to know what you want to do and go after it. So I could certainly see, kids in a third world country who could really benefit from a physiatrist because maybe they had a traumatic brain injury, or maybe they are an athlete in a third world country and they need, or they recently had an amputation. I think there's certainly opportunities, and PM&R is new and broad enough that you can really make it what you want it to be.
Yeah, that's great. It's good to know that there's so much flexibility and so many opportunities to come out of that residency program. So that's really a great option for so many people to consider. And I guess so finally, what advice would you like to give for any of us struggling during the pandemic to get through and get hopefully into medical school?
Yeah. I first of all, I want to say that I admire you all for sticking with this. I think it's, for everyone, just a really difficult time, for residents, for attendings, for medical students, for pre-meds, for college students. We just don't really know what the future holds, but we're gonna, more and more, we need physicians and we need people to come into healthcare and help us with everything that really is going on, because with all the COVID-19 cases and all the repercussions, whether that's mental health, there's a lot of stuff coming out about mental health, whether that's patients post-COVID as well at a rehabilitation hospital. We really need the manpower, or the woman power too, to get through this. So I think just stepping back and remembering why you're doing this, and that you're part of something that, we're all rooting for you, especially as pre-meds. I've got to say that's one of the most difficult times within medical training. Like I said, it keeps getting easier. And being a pre-med is kind of one of the hardest parts along that spectrum. So I guess that's not really anything concrete, except to say that I know what I guess I can't say that I know what it's like, because I wasn't a pre-medical student when COVID-19 was happening, but I've been a pre-medical student and I know what it's like. I'm happy, if you want to reach out to me, if you want to reach out to me and ask me for other people I can connect you with as well too, or other residents. I'm happy to support you guys. And really, I just appreciate that you guys are all here and sticking with it. So
great.
Thank you so much. We really appreciate you giving us your time, especially on a Monday night, the beginning of a long week, but hopefully you had a good weekend. But thank you so much for being here, giving us your great advice. And thank you everyone for joining us and asking such amazing questions. We hope everyone has a great week. And yeah.
There's, I don't know if you can read the chat, Dr. Swenson, but there's a lot of thanks and praise for your talk.
Oh.
Go ahead and look at that.
Thank you all for being here. I really appreciate you, and don't hesitate to reach out if you have any questions. And I appreciate you too, Yasmin and Lana. So
of course.
Thanks for having me.
Have a great night and a great week.
All right. You too.
Bye.
Bye.